you is, what is a book that you recommended most to other people, or books, depending on how frequent you read?
Yeah, and I have to be totally transparent. I don't tend to read a lot of long format books now, and that's probably sad, but I do have some books that I've used and found really valuable and still recommend. One of them is called The Influencer. It's by the same author group that did Crucial Conversations, so probably pretty easy to find from that. I will tell you, if you work with human beings, it's an absolute must. What I've learned over my career is that execution, once it hits like the tar pit of influence, if you don't know how to traverse that during implementation and maintenance, then you're going to get fossilized. So I would recommend that one. The other one that's I think maybe of interest to this group because it is CareOps is one that I found pretty fascinating. It explained a lot of what I was seeing from a operation standpoint, and it was called Thriving at the Edge of Chaos. It's about managing complex adaptive systems. And that's really, again, kind of paired together with really recognizing kind of human behavior and the complex beings that we are when you're trying to set up really a care process and trying to anticipate, right, how that's going to behave. It was very helpful for me in trying to manage and redesign operations.
What was the second book again? Someone in the audience
Yeah, the
asked.
second one, and I'll post it in the messages or in the chat. It's Thriving at the Edge of Chaos. It's by Jonathan
Nice.
Sapir.
We will see an uptick on Amazon after this webinar.
Yeah.
Kerem,
I
for you,
get no
what's your
commission.
uh, Kerem, for you, what's your favorite books or book?
Mine's like totally opposite side from Sujal. I usually recommend this little book called Ingredienti. It's a cooking book actually by Marcella Hazan. It's like note card sized almost. And it just has three sections kind of broken up into how you'd build a pantry and what to look for when you shop. And it talks about ingredients and how to use them. Doesn't give any recipes, how to spot them, flavor profile and whatnot. And it's a lot about editing and what not to include with other things. But I always give that to people because I love to cook. I cook a lot and I don't really look at any recipes. And people often ask me why or how, and it's an easy thing to hand off to them. There's like usually a few copies at my house that I give to folks.
Kerem's really a chef at work as well. This is the first time I'm hearing about this book, but this explains a lot to me.
Yeah, it's all about editing, Sujal. Less.
And the ingredients. You don't
Yes.
have great ingredients to start with.
Totally. Yeah.
But Thomas and I are into cooking as well, so I will definitely order
Great.
that book. And maybe another question before we jump into the conversation. What is your favorite movie or TV show that you recently watched, or something that you rewatch every single year with your kids, for example? Kerem, maybe you can start. Yeah.
Yeah, so I have three little ones. I don't have time to consume anything for my own pleasure, but I do like having the kids watch things that we watched growing up. And right now, the kids are really into The Sandlot, which is a kind of like a coming of age story baseball movie. And my son's just old enough to enjoy it. My daughter's not really old enough to enjoy it, but she knows her brother loves it, so she gets a kick out of that.
I'm gonna have to recommend The Princess Bride because I think it's a movie that just has a genre for everybody. And also, honestly, it's something you can watch with families at every age. So to me, it's a classic.
Cool. So we can, as of tomorrow, read more and watch more. So that's perfect. All right, we can dive into the actual topic of today, which is how carbon health does CareOps. And before we jump in, maybe Kerem, can you briefly introduce yourself to the audience to set the stage of why you are here today?
Sure. Kerem Ozkay, I am the Chief Operating Officer at Carbon Health. I've been with Carbon for just about 5 years, almost 5 years. My background's mostly in marketing, customer acquisition, retail operations, and kind of the intersection of all those things. Both online, offline, omni-channel, all those buzzwords, but really tend to focus on businesses that have a physical presence. And so when Aaron Bali reached out about coming to Carbon, I actually did not want to. My wife had worked for Kaiser for years and years and years, and I didn't want to be in healthcare. But he kind of wooed me into it, and over the last few years, I've learned a lot about the clinical operations through a lot of the M&A and diligence that we did on that side. And when our chief operating officer stepped away about a year and a half ago, Aaron tabbed me for the role, and I first said no, thank you again. And again, he convinced me into doing it, and I've enjoyed it since. Yeah.
Nice. And yeah,
sorry,
go ahead,
Rik.
Dr. Sujal. Yeah.
Yeah, I'm Sujal Mandavia. I'm the Chief Medical Officer at Carbon. I've also been at Carbon for just about 5 years. In fact, Kerem and I think we started probably within a couple of weeks of each other. Team was a lot smaller back then. I'm an emergency physician. That's my specialty in training. I'm still practicing clinically, which I think is important for me because it keeps me connected to the work that we're supporting and the work we're designing. My career, I've really kind of I probably wasn't as efficient or goal oriented as I could have been, and I meandered through academic practice, community. I spent a long time doing physician management, which is actually where I got my introduction to operations and operational design. A lot of which was actually done in the emergency department, which is, I will tell you, has extra points of difficulty just with all the random arrivals. And when you multiply that by really wide variation in condition and acuity. So that's kind of where I cut my teeth on that. I often joke that I'm a doctor who knows math, but I credit a mentor who actually was a physician who studied math. And so he was the guy who actually did queuing math, which really helped me understand, again, how to design and monitor systems. In my role, I'm paired up with Kerem, and really we're responsible for all the operations, along with some other things at Carbon.
Nice. And Thomas, can you also introduce yourself today?
Sure. Thomas, co-founder and CEO of Awell. I'm also co-author at CareOps. Awell is a software platform that's used by care teams to design, implement, and continuously improve their clinical workflows, patient journeys. We call them care flows in general. So that's what we do. And our mission is to make care flows work harder than care teams.
Yeah, and I'm Rik. I'm a trained oncology nurse, and I lead clinical strategy at Awell. So I implement our software and try to improve outcomes. And then in my spare time together with Thomas, I write about all the stuff that we see and learn and interview smart leaders like Kerem and Dr. Sujal to better do our job, but also allow other people to do their job better as well. So cool, thank you. Maybe before we dive in, what would be helpful, Dr. Sujal, maybe can you briefly explain to the audience what Carbon Health North Star metric is? And is that North Star metric different for you than it is for Kerem, or do you have one North Star metric across the organization?
Yeah, I would say our North Star metric in the last year has really been centered around cost per visit. And I'm saying, I'm the doctor, and I'm saying this, and I it could feel like that's kind of icky because it's financial, but I actually don't think it is, especially from the perspective of a clinical leader, because it really helps us capture a lot of the work we do to achieve really the quadruple aim. So I'd say cost per visit, but really we balance that with other metrics around quality and experience to make sure we're kind of really hitting the target on what we want as outcomes and experiences for our patients.
Yeah, I'm just going to build on that a little bit. First, that makes me so happy to hear you say that.
I do learn.
These things where, to Sujal's point, it does come off as very commercial at times, but our mission being making great care accessible to everyone. The everyone piece really does require us to focus on what the upper and lower bound of what we can deliver is. And in order for us to be able to service all audience types with all insurance types, it does require us to run a very lean operating model, because we're not really in the business of expanding our margins like crazy to go and build high profits. It's mostly about how do we give the best level of care that we can in the space that we play in, and the environment usually really dictates what we make from a revenue standpoint.
I'm going to add on to that, which is lowering the cost of healthcare is hard. And I think it's why you don't see folks talking about it as much. But I think until we do that, like what are we doing? Honestly, I would tell you that, if you look at some of what is happening right in the Medicare Advantage space, it probably gives you a glimpse into, teams were better at creating revenue than lowering cost. And so when that got squeezed, they felt that pinch. And I think we as an industry need to be spending a lot more time on lowering costs.
So just a quick observation here or a question for you guys. So I hear you use the words icky and commercial, but a core tenet of CareOps is all of the work that was done around total quality management. And so in the roles of production, it is known that quality and cost reduction are actually tightly correlated. So as costs go down, quality goes up, and the inverse as well, by the way. So how come that the healthcare industry has not adopted this viewpoint yet? Is healthcare the only industry in the world where this correlation does not work, or what is that?
I have two answers for that. I'll let Sujal go first, but
well, I was going to say, Thomas, I would say you're spot on. And actually, it's not that it doesn't work in healthcare. It's just that it's not commonplace in healthcare because many reasons. And I won't go into those because we could spend the whole hour talking even about that point. But I agree with you. And I also think that even productivity, which is another kind of icky word sometimes in healthcare, is also linked with that. And it's been my experience. When you design systems that have to operate in constrained environments, it forces you to have the discipline to actually create good process, to monitor that process. You know that the process and the resourcing is working for the demands, and like looking at actual outcomes to see if it's working. It's when you do that, and especially if you can empower your teams who are actually delivering the care or the service, now all of a sudden there's a mindfulness that I've seen get switched on in teams that doesn't exist when you don't do that, which is what leads to better quality outcomes. And that actually is a really great platform upon which you can just continue to build. It's very strong.
That was one of my answers. The other thing I would build onto it is it is one of the only places where we don't actually spend the dollars out of our own pocket, and you're not conscious of what you're spending as a consumer on that front, whether through insurance. Yes, you see your copay and whatnot, and a lot of it gets plucked out of your paycheck before you even see it, deal with it. But because of that, there's also this expectation that the quality that I get and the care that I get should be consistent across the board. And on the operator side, we don't really talk about money with the patients very frequently. There's a little bit that you talk about on the front end, and because that conversation doesn't happen within a practice generally, it's also this thing that seems like a very foreign concept to the folks running the clinic at the same time, or the hospital system, whatever it might be. One of the things that we've really focused on in the last few months, I would say, is bringing that conversation to the front with the patient. We're giving them an idea of what their EOB might look like, the total cost of care actually before the visit. And then so they understand what care they're getting, what the cost of that care will be, and the expectation of what that visit might look like in that same time. Partially because it's great for them to know, walk in there with an expectation of what might hit their debit card, their credit card, their insurance. But also it sets this environment of like, this is a transaction at the end of the day, it's not a negative thing. That is a positive thing. We're providing a service to these patients, and also help them understand that we're also a business at the end of the day.
I think too, I'll take my perspective as a physician. I actually think it's very refreshing. What Kerem said is absolutely true. For the longest time, there was clear siloing between the economics or the finances of healthcare, the revenue cycle, and the care. And that needs to be broken down, because I will tell you as a physician, when I get to have a conversation, an informed conversation with my patients, because they have awareness of what this is going to cost them, and we can then have a much more meaningful discussion about a care plan that's right for them. Not trying to compromise, right, but more trying to make a really great shared decision.
Yeah, that makes sense. And then so when the Aaron and the rest of the leadership team decides, okay, as of today we are going to focus on cost per visit as our North Star metric. What was the initial idea of like, okay, let's focus on this, and then we will know that the cost per visit goes down? And what is the thing that actually moved the needle? Because we have a lot of ideas of like, if we do these things, then cost per visit goes down. But once we go into implementation, we see that simple stuff like adopting the CareOps mindset, adopting Lean Sigma, and all of that already moves the needle significantly. So what is something that you learned there from an ops perspective, Karen, maybe?
Actually, I'm going to kick this one to Sujal, mostly because there were a few things that we were doing in the background and had an idea where it would go ahead of time. And Sujal's team actually was the one that had to implement a lot of this on the clinical side. So pass that your way, Sujal.
Well, and I think Kerem's being too humble, because there were a lot of things that we did as a business and on the operations side. So I'm going to kick it back again to Kerem, but I'll start with what we did on the clinical side, which was really developing that awareness of the cost of care. And it was actually really amazing. Honestly, I remember when we as a leadership team were talking about introducing this to the teams, I was a little bit nervous because I wasn't sure how it was going to land and whether it would feel icky to the teams. But quite honestly, they embraced it. They wanted to understand basically the consequences of the decisions they were making many times a day, and what impact that was having on our patients, on the practice, on the sustainability of the business. So we were able to achieve better standardization of our care around decisions about like what supplies we would stock or wouldn't stock, what was a reasonable use of some of these things. Like, for example, point of care testing is something that we have been huge adopters of, and I'm still a massive proponent of it, but we've got to be great stewards, because if we're using it just because it's there, we can, before you know it, you can really inflate the cost of a visit for that patient and I think we need to challenge ourselves about whether we're actually delivering extra value when we're spending extra dollars for that patient's visit. So I would say it was actually easier than I anticipated. We really sought to do it from an approach of transparency, like extreme transparency, like really talking real numbers, not just talking about concepts. And I think that was part of why it became effective, because we weren't just trying to speak at a very high level and almost talk down to our providers. They're really smart people. Again, I went into medicine because I was told there'd be no math, but they understand math and they get it. And they also want to do the right thing. I will tell you, that's one thing that's universal in healthcare. Like that is the lever that we all have in front of us, is that the patient is the center and we want to do what's right for the patient. So we're really fortunate that way, that we have a common ground.
And just to build on that, we wanted to keep the patient at the center of it. So one of the tailing metrics that we had as we talked cost per visit was our NPS, patient satisfaction, and kind of our external reviews at the same time. And we ended up breaking down the cost per visit metric it's a velocity metric. So there were ways to build up volume to drop the cost. And then obviously there were things that we were doing to reduce costs. So it didn't feel like we were constantly taking from the teams. It was more of a trade-off in terms of like, hey, here the thing, or in some cases it felt like we were taking when we were throwing more volume at them. But it was basically letting them know, this is the way we're going to go attack the revenue side. This is the way that we're going to go attack the cost side on this. They built together, and then we incentivized the staff on the other side to go and increase the throughput once we had the cost portion stabilized. By the way, I'll like a lot of this was, I know we'll talk tooling at some point, but a lot of this went hand in hand with what we were able to do on the tooling side. Like Sujal and I can go tell people to go do these things, but that only goes so far. The one thing I've learned personally is I can't get a provider or clinician to do anything unless I give them the right tools and the right construct and framework to go do it.
Yeah, I think that's a great segue to the next question, and maybe tooling will go beyond tech, and then feel free to explain what you mean with tooling. But we wanted to dive a bit deeper into Carbon Health's approach to technology. There's a blog post that we will also link in the notes and wherever this is shared afterwards. A blog post by your CPO Ayo, that to build a differentiated tech-enabled services business is, as Carbon Health points it out, building an integrated software. That's one of your main value props. So could you tell a bit what are the main components of that integrated software that you've built, which ultimately, you know, provided your clinicians with those tools, that tooling that you just referred to?
So Carbon actually started as a tech company. Built the EMR all in-house. Originally, plan was to go to outpatient care and go license the tech. And what Aaron learned very early on was that two things. One, Aaron Belly's our CEO and founder, but one of the things that he learned was the information that he was getting back from clients or potential clients was really focused on either the way they delivered care or gaps that they had in their product. And then also just the ability to go influence what that product might look like to the care delivery side. It had to be full stack. So we ended up acquiring an urgent and primary care chain, and eventually we built out our own clinic base, and we have now 120 clinics where we basically dog food the tech. It's not quite that extreme, but that's where we're running our EMR, billing, care discovery platform is what we call kind of the patient-facing side. We have our own patient app. We have an operate platform, which helps us manage the practice, but it's a full operating platform for an outpatient care center. So we run urgent care and primary care. We work for specialists as well. Probably anything other than like dental and veterinary, kind of in the health space. But what we've learned over the years is that one, we have to get the provider experience right within that. And once we made that leap through that, and Sujal will speak more to that, we started to focus on the things outside of that care. So between the patient experience, what happens at top of funnel into the EMR and out into the clinic and out, then what happens on the back end with messaging and billing and whatnot. But the main thing that I think we do really well here internally, at least in our care delivery organization, I'm going to separate what we do within our clinics and from the tech, is we try and get people to do things via process. We have a wonderful clinic ops team internally that does a really good job working with them. And then once we realize that something can't be done with human process, that's when we take the problem over to the tech team and say, great, this is like an actual issue we have. Can you please help us solve this? Here's the end result we're looking for, and we pass it off. Like Sujal and I don't sit down with them and say, this is the feature we need built in this way. They are highly intelligent. They're incredible at what they do. They'll come back our way. Sometimes they knock it out of the park first time around. Sometimes it takes a few iterations. But ultimately, we give them the end goal in mind. And then because they're integrated into the care setting, they can go and see how it works. They know the providers. They know everybody within the clinic and have a good understanding. I get that going as well. So they're not out there to just go build features that might sort of sell software. They're really here to help us build out an integrated platform that really helps us drive efficiency within the clinics.
Yeah, I mean, honestly, it's really about solving problems, actual problems, not just what you think might be the problem. And I know that you, and I'm sure your audience appreciates this too. Healthcare is so complex, and there are a lot of different constraints that are hidden underneath the surface. And that's why you see the kind of behavior you do, or the performance that you do within a system. But really what Kerem said, I think, is I want to underscore, which is the sequence for us was very important. We've been guilty sometimes of building features and then realizing that actually that wasn't the right solution for the problem, or that was not a problem, and you just built a feature, but it's not really of that much value as a result of that, but really observing, taking operations that were at least hopefully well designed to start with, or maybe not even, and then recognizing where those gaps are, and then really doing things very intentionally in a manual way first, so we understand and get really deep insight into what would we need the tech to do. Because really at Carbon, the tech becomes, it's activated as another team member. I'll put it that way. So it really becomes part of the supporting cast of characters that supports me at the bedside with a patient. And it, just as Kerem said, like that moment is actually that's where everything backs out from there for us.
So you both mentioned two things that I'd love to dive a little bit deeper on in a follow-up question. So Kerem, you said you first made sure that clinician experience was nailed before moving on to something else. I think a lot of the people in the audience, I know that a lot of the people in the audience are looking at exactly this, right? So clinician, talent is highly sought after, and these days clinicians can just go and work almost everywhere, or much more so than a couple of years ago. And so both Rik and I are very big proponents of indeed getting the clinician experience right. But a lot of people are trying to do this. So can you, like in really practical terms, say how you approach this at Carbon Health to make sure that that clinician experience was nailed?
I'll let the doctor answer first, and then
I'll go first. But honestly, Kerem has insight into this too, and that's part of why he's good in his role. Here's what I would say as a guiding principle. Actually, I'm going to reflect back the words you said, Thomas, that really the process should work harder than the clinician. And I'll say it a different way. If the process you're designing or the system that you're designing requires the provider to work harder than they were before, it won't work. I mean, that's like a Captain Obvious thing, but it's, you'd be amazed at how often that happens, very unintentionally, because you might have a group of stakeholders that are designing something, and if they truly don't have the perspective, the real world perspective of how things will actually work for the teams that are directly doing the care, then you can really miss that. And even if you're off by 5 degrees, that's too much. The other thing is we really try to keep things as simple as possible, because the reality is the delivering the care itself, again, the moment between a patient and a provider, the provider's trained for that moment for years. And they often know how to do that well. And we don't always need to get in between those moments, if that makes sense. It doesn't mean we don't want standardization and some guardrails, but we don't want to interfere with that too much. And what I would say is that when we roll out new features, when we roll out new programs, the guiding principle I give to our team is, hey, for the provider portion, if the training is larger than a cue card, then we've failed. Because it should probably be a blank cue card. Like it's just like, hey, it's a magical moment where things just work better for me, or there's very minimal things that I have to do differently as a provider. I would say that's one component of it. The other thing too is really being very intentional on having your care team, which I don't think that there's probably anybody who's in this audience who would be designing a process that only has a provider in it, because that's just not an efficient use of that really precious resource. So when you have a care team, and I would include the technology as a member of that care team, everything should be done in a way that is preserving the time and capacity and cognitive capacity of that provider so that they can do more. And again, we talked about productivity earlier. That can be a dirty word in healthcare, because often productivity is just something where you're getting people to see more patients, do more, but you're not necessarily giving them tools or process that makes their job easier. I've been very delighted by what I'm seeing us do, with all of our tooling we've already built. Now we have a very AI first approach to our technology, which is unlocking a massive amount of time back for our providers, which also improves their satisfaction. I will tell you, I can't imagine myself working outside of Carbon, even though I do, in the hospital sometimes. I feel like I'm working with Stone Age implements compared to what I have, which is I get to do my job as a physician, and I don't have an extra job that's always following me around all day long because I have to do documentation and other things that are really not value add to me.
Thanks, great insights. There's another concept I'd love to unpack quickly and really get to how Carbon Health is practically doing this. So defining the right problem and then making sure that your solution has solved that problem is another one of those things that I know the audience is very curious to know how you're approaching it. So do you have like a specific methodology that you use to define your problems or cadence? How often do you do that? How are they formulated? Is it clear for the whole organizations, like we're tackling these 3 problems next? How do you do that at Carbon?
So it can't be org wide here because we do have the tech, the product side and the care delivery side. We tend to break those things up. Overarching, they are the themes are similar so that they're all working towards the same initiatives. However, we are very, very data oriented here. I'm not going to say we're slaves to data on that front. We definitely take a qualitative view to the data as well. So we'll see something, we'll see some trends, and then sit down in a clinic, listen to phone calls, speak to patients, our practice managers, and understand what's going into that. And just a very clear example is last year we had we felt like there was more demand than we could accept within the clinics, and that were coming through in terms of what we were seeing in just pure volume. And started to listen to phone calls on that front. We found out we were turning away some patients. We were telling them to go elsewhere. We were giving them false information, not so much because of out of nefarity, just more the way the practice was working in the background. The clinic was working in the background. So we ended up sitting down and looking at our volume metrics, our call volume, what's coming through on the booking side, our cancellations and whatnot, and sat down with the product team and said, all right, we have this core issue, and it's not necessarily a behavior that we want to change on the front end. It's a behavior we want to change in the back of house with the providers and the MAs. And it was mostly around the way that what we learned was the way the schedule board was showing up for them. It felt like they were underwater, even though they may not have been, because everybody that had a booking over the next 6, 7, 8 hours showed up there all at once. So there was no concept of time and throughput within the clinic at that moment. Sujal did a wonderful job of working through this with the clinicians and adding process on that end. But really the core problem we had to solve was first actually a product problem for us. The way that we were taking in patients, the way that we were treating them once they were within the system, who was in the waiting room, who was in the virtual waiting room, who was actually in the clinic in the back, and then who were they taking care of on their way out, basically, who hadn't checked out yet. Because that's all tax on the teams. So we ended up breaking down what we deemed demand to be in terms of a metric, what we deemed actual throughput productivity to be. It turned into a velocity metric and came back to the teams and then showed what the various pinch points were and then measured growth within those. Does that kind of answer your question, Thomas?
Yeah, absolutely. And it's kind of a segue to the follow-up here. The audience is also really curious about the tech really that you built at Carbon. And so referring back to that article earlier, you have a strategy to build most, if not all, of your tech. There's a lot of talk in healthcare about enabling clinicians to work at the top of their license. But what about engineers? What does it mean for Carbon to enable your engineers to work at the top of their license and spend your precious engineering resources only on the things that matter most, and then buy everything else? What is the approach there?
So we do buy some things. The things that we end up building here are core to what we think would build out a better product for the operators of the clinic. So there are certain features that, yes, you could say you should have. Actually, I'll give you a clear example. We use Twilio. Twilio sends out all the messaging on this side. We could have absolutely built that. We could have figured that out, but it's a back-end thing that the individuals in the clinic don't actually touch. So when we say we build everything from scratch, it's mostly if you're running the clinic, and you're sitting there as a provider, an MA, a support staff, a practice manager, you would see it all as one tool. There's nothing external that we use within the clinic. I want to make sure I keep myself honest on that. Outside of like email and Google and whatnot, because people have to communicate. All that happens within the EMR. And we're very selective about the things that we want to build and integrate within that flow. Because there are certain things that happen within healthcare that I think are kind of ridiculous in the ways that it adds costs. It's a lot of licensing fees, and everybody's got their hand in somebody's pocket through this process. I'm not going to name any names today, but there are ways that you can, again, come back to having a more efficient product, reducing the overall cost of care by going out and building those things and actually finding the source data, as opposed to using an aggregator or a third party.
Yeah, I think there's so much fragmentation, right, in healthcare. It's like a fractal. It's fragmented when you look at it, when you zoom out of the whole industry, even when you double click within a practice that's highly fragmented. Often, when we would acquire a practice, we would see that they're using sometimes up to like 15 different tools that were patched together. We can rip all those out and replace them. But each of those fragments come with a tax, right? So I think that there's inherently, not even in here, there is actual efficiency we unlock because of that. Getting back to your question though, like how do we respect the engineering resource for what it is? We have a principle that we operate by: respect the craft. And that's actually whether you're a physician seeing patients, whether you're an engineer, almost regardless of which role, we really want to make sure we're mindful, right, of that resource. There's a very tight integration between our clinical team and our engineers. And that's really from day one. When Aaron Bali had set up the company, and Kerem had mentioned initially it was software, but Aaron did open up a clinic, and it was really meant to be that lab, so that they could directly, literally have engineers and doctors sitting next to each other, observing each other. And that was our DNA. That's how it was forged. We still behave like that today. We have a clinical specialist group. I was just on a call with them this morning. They work very closely with our product team and engineering team so that there's a tight feedback loop. And what I mentioned before was, what we've learned as a best practice is, don't just have the engineers run off and start building things. Let's stay very close to each other. Let's monitor, let's define, right, the problem. Let's define what metrics we're associating with that, so we can really measure whether we're building something effective or not. And let's do it manually first, so that we know we're coming to the engineering team and the product team with a clearly defined problem, and then relying on their craft as an expert in designing product and engineering solutions. And I think we've gotten a lot more efficient than we probably even were a few years ago.
Makes me really happy. One of the reasons I left, or I'm not a nurse anymore, was the fact that whenever I was providing care, you had like 15 tabs open with up-to-date or a protocol that was printed on the wall. And it's the type of stuff that obviously sucked very soul-sucking. So the fact that you focus on one tab, reducing the cognitive load as much as possible is exactly why I'm also in tech right now. And so, Dr. Sujal, you mentioned a lot of we talk about the problems and then we let the smart people in the team figure out the solution for that. On your website, you mentioned that you focus on a lot of different specialties. So you have LGBTQ plus health, you have women's health, you have primary care, urgent care, all of that. So let's say that tomorrow you want to roll out a new care delivery process focused on a new patient population. Where do you start? Is it then going to your team with saying, hey, we've seen these problems coming up for this patient population and we now want to have a solution for that, to go figure it out? Or is there more guidance and process in that, from designing it to also implementing it?
Yeah, I'll describe our process, and I'll start with the inputs, which are like, where do these sources of inspiration come from? And for us, it can actually come internally from our staff or providers, because they recognize that there is a gap that they're seeing. It could be our patients who are requesting services and we realize we don't have those services, or it could be the market and we just kind of recognize externally that there's something more or different that we could be doing. So when we look at those, we have a process that's integrated with our ClinOps team, and we assess those projects based on what are the capabilities we need to deliver that service. Do we have those or not? So what's the kind of delta of new capability that might need to be stood up? But a lot of times the basic ingredients of a service may actually already be there. Like i.e. the Lego blocks are there, but we just need to kind of reassemble them in a way that makes it feel like a very supported process. And then we look to, or I look to, and we have a clinical council of sorts that will look at the actual care that needs to be delivered there. Are there evidence-based guidelines that exist? Any society guidelines? Those are helpful, but not always available. And I'll give you some very concrete examples. Obviously, we know we just came out of a pandemic. During the pandemic, there were no society guidelines because things were moving way too quickly. So we became the society. We were scouring the literature. We're very much want to operate from a base of evidence. We don't like to just do conjecture, especially if there can be any risk associated, which there often are, even if it's not obvious. So we did everything from an evidence-based. Oh, shit.
You're still with us?
Oh, good. Okay.
Sorry. We'll have to cut that out.
Maybe you can edit that out. My screen just went blank and I thought I dropped.
No, you didn't.
Anyway, we use evidence. We believe in that, and then that we layer on top, and then we also need to look at what's behind, like underneath the surface. And these are the things like understanding how we will acquire patients or really merchandise the services, and then also how we're going to get paid. And quite honestly, that's the part that is the most complicated and sometimes unintuitive, where there can be circumstances where we develop really great programs and services, but it will fall down because we don't have the mechanisms to really capture the reimbursement we need to keep that service sustainable.
Yeah, just to build on that, we've moved away from looking at our business in terms of, and we talked cost per visit pretty heavily in this call, but we look at productivity and margin across each service line, each visit type, kind of each CPT, ICD-10, etc. But that's also fed upstream in terms of, to Sujal's point, on the marketing side, in terms of how we acquire patients, what we're willing to do from a marketing side to go acquire those patients. And then we take those into our conversations with the payers to really let them know, like, here's the available audience for us. Here's the cost of care to us. Here's what we expect to get. And if this is care that you would like for us to deliver on your behalf to your members, this is what we need to go get paid on that front. So team does a wonderful job of negotiating with payers, not just in terms of like rates, but also the types of care that we're going to offer and ultimately, what do we get reimbursed on that, and if it makes economic sense for us to go do so.
And so you talk a lot about the financial part and also the operational part of improving your processes. But obviously, me as a nurse, I'm still in healthcare to also improve outcomes in many ways. And outcomes can be the NPS, but can also be life expectancy, or more importantly, quality of life. So how do you look at that from like a medical perspective? How do you track that, and how do you know that whenever you design a new care flow or a process, that you'll actually move the needle for patients as well, besides only looking at your bottom line?
Yeah, Rick, it's a great question. And again, like none of these things, we do these things in parallel. So in the process, that's why I mentioned earlier, we probably are guided by the quadruple aim, even if we don't always call it out very specifically on a slide. So, as we're looking at these care programs or services, where applicable, we will identify what the outcome measure is. And those could be a HEDIS measure. It could be, some other type of outcome measure or process, even a process measure that we can measure. Because remember, again, you mentioned life expectancy. That's not necessarily what we can measure, or nor would it be, rapid enough for us to be able to understand whether we're doing something well or not. But all of those things are baked into our process, and we also will then transmit those out very transparently to our team. So like we have a provider dashboard that's pushed out weekly, and we have about 8 metrics on there that we're tracking, including quality metrics, so that our providers know how they're doing very specifically on what we've kind of decided as a group is important.
And so one of the programs that you had was your diabetes care program, that there was a lot of results published on how it moved the needle in many ways for your patients, but you still decided to shut it down. So what triggered that decision? Was it really because you started focusing on cost per visit and you saw that the benefits of running that is just not worth it, or is it something totally different? And I see Kerem nodding, or not nodding, disagreeing. So feel free to tap in here.
We could have made the economics of that program work. This one's an unfortunate one where we're just kind of at the crossroads of where the kind of payers to providers linkage doesn't really work. We didn't have access to those patients, and it's really unfortunate because we did a wonderful job managing the care. We showed improvements in on the care side. And it was such a small N of patients that ended up trickling in because we didn't get steerage, whatever you want to call it. And it wasn't a thing that we could traditionally acquire direct to consumer. That's a thing that we're very, very good at. But the types of audiences that we took care of, they had providers on the other side, or a lot of the payers had to push them towards a program like ours. And this is a case where we probably get kicked for this one, where the end outcome of the improvements in that patient's care wasn't enough for those that do pay for the care to care about at the end of the day. And so like, I'll let Sujal build on exactly what we did there, but it wasn't necessarily an operational efficiency thing, or it wasn't because of cost per visit. It was mostly around making that work at scale for us.
Yeah, and Rik, especially knowing your clinical background, one of the things we're often taught when we learn about the pathophysiology of diabetes is the role that insulin plays. And I know I'm diverting a little bit, but it'll come back, trust me. When you do not have insulin, you can't get glucose into the cell where it's needed, right, to fuel processes within a cell. And there's a phrase called starvation in the midst of plenty, which means that your cell is starving because it can't transport that glucose in. Our diabetes program was starvation in the midst of plenty. We had plenty of demand. We had medical groups who were really interested and wanted to be able to send patients to us. But again, underneath the surface, this is what I was referring to before as well. Underneath the surface, the complexity of the payer reimbursement meant that there was no easy way to make that happen. And we just weren't in the stream of the both referral flow and the economics in a way where we could participate in a very meaningful way. So that was really unfortunate. This program, and I want to take 15 seconds to just tell you about some of the results. I mean, we took patients whose A1C, a measurement of control of diabetes, and you want to be definitely under 8. You really want to be under 7 to be well managed. We had patients who were not managed well and would come in with A1Cs of 10 or 11, and within 6 weeks, we'd have them 7 or less, and that was sustained. It wasn't just a one-time thing. They were sustained over months and months and months. So it was very sad to see that go, but honestly, I think it's a great example or almost case study for your audience that this was not only a great idea, there was clearly a need. We had performance metrics we were meeting, but we didn't really anticipate the added layers of complexity to drive the financial sustainability of the program.
So you made an amazing analogy in the beginning, Dr. Sujal, the tar pit of influence, and then if you're not unable to overcome it, you get fossilized. What you're basically saying, if I can cut some corners here, is that the best product doesn't always win in healthcare, right? And so if we tie this back to SaaS businesses, for example, there's this trope that you need to be 10x better than an existing solution to be able to change behavior and make people, make a decision to adopt your solution instead of the status quo. And so this is clearly a case of where payers just, did not have enough pull to go away from the status quo and sending you more patients, basically. That's ultimately what it comes down to, as I understand. So
sorry, go ahead.
Yeah, no, there's a question coming. Sorry. So in the CareOps principles, right? Continuous improvement would allow you, if you're obviously able to sustain it long enough, to get to that 10x improvement that would be attractive to the payer or to anybody sending you those patients or kicking off that reimbursement. What are your thoughts on this?
So I agree with you, and I think that the adage of 10x or 100x better is the way that you overcome legacy is true. But actually, what I would tell you is that that's a bit of a blunt instrument, meaning if you have the ability to see where you can overlap and have a very small area of focus where all things layer on top of each other, the service, like the need or the demand that's there, the service offering you have, the economics, and also the implementation, i.e., will the teams who are actually supposed to use this product actually use it? If you can get all those things right, you actually don't have to be 10x better. You probably just need to be 1.1x better, and it will actually start to grow and flourish. But I think it is probably seems easier to be 10x better because it's very hard to actually get all of those layers within focus, if that makes sense.
Yeah, I sort of agree. I'm going to disagree a little bit with one of the concepts here between the two of you. The patient outcome doesn't really define product market fit here, because who we're really having to sell to is the payer. And to your point, Thomas, the payer just didn't care at the end of the day. Some of them did for sure, just not enough at scale for us to make it work and for a long enough time. If we had kept at it for 4, 5, 6, 7, 8, 9, 10 years, probably could have. It is a program we will absolutely come back to one day. But with where we were as an organization, we just didn't have the time to be able to invest in that. So the product market fit piece missed on actually who was paying for the product. It was great for the patient, it was great for the provider, and missed on that piece.
Yeah, and again, that's where it was hard for us, clearly, because we didn't get it right, but it is hard in general to really have deep insight, deep enough insight, right, of each of these components for success. But if you can get all of those right, and if we anticipated the payer behaviors and dynamics ahead of time, we would have actually built towards it, which we didn't do. So that's kind of the point I'm making. If you could actually nail all those things, you don't actually have to work as hard, but it is very difficult to do that ahead of time because a lot of these things are opaque.
Yeah, I don't want this to sound like I'm anti-payer. We're like 99.9% of the time aligned on things, and they've been wonderful partners to us, but also I do think they provide a great service. It's just there are a lot of factors in how we get reimbursed and kind of the care we deliver within that environment.
Well, and I'll say it a different way too, because I agree, payers can be great partners. I think what we as builders and operators need to understand is if what you are building and trying to operate is not necessarily backwards compatible with how things work today, then you should just anticipate that it may not survive.
Yeah.
So I see we have 5 minutes left, and I maybe want to ask one last question. So you definitely changed your approach to do CareOps multiple times, according in the past years that you've been at Carbon, and also you as an organization. So can you maybe explain to me what you have done differently today, or something that you learned today that you would have done differently if you could go back in time, besides focusing on those cost per visit metrics and besides prioritizing the clinical experience? Anything that we didn't touch upon that you think you would give away to other people in the audience to say, like, if you can do this tomorrow, please do that, because it will really move the needle for your business in the years to come?
So many. I'll go second because I want to parse through these. There's so many in my mind.
Okay, I'm gonna go with because I have many, but the first one that leaps into my mind is be ruthless about simplification. Just absolutely ruthless. Because yeah, just because. I'm not even gonna expand on that. In the spirit of keeping it simple.
Yeah, I think there's that, and then a thing that we've changed in the last year. So it comes down to simplification, but and Sujal says this all the time, skate where the puck is headed. That is a thing that we've done really well here, where at times, because of the nature of us being a startup or us being a product company, technology company, you can kind of create your own lane in a lot of different ways. And we've done that at times. But what we found has been most successful is have an eye on where the industry's headed, where the patient's headed, where the provider's head's at, and just make sure that we do that better and make sure that we can do that consistently. And that has helped us make us much, much more successful than in the past, where there were a lot of ways that we could make a difference and change. It's just probably not ready for it. We're not ready for it. Industry is not ready for it. Not wrong place, wrong time type situation. But definitely my biggest takeaway from last, I'd say 2-3 years is that there's always been an obvious answer, and us running towards that's been the most successful path for us generally.
Great, thank you. That's it for today. Time's up. For people that are still here and want to also have a CareOps t-shirt like myself, you can fill in this form and provide some feedback on today's panel. And then I will send you one. And then Dr. Sujal and Kerem, if you want a t-shirt, I can also send you one as well that you can rock at practice or when talking to your teams. And next week we will announce the next panel as well. But thank you for your time. And thank you for the audience for joining.
Thanks for having us.
Thanks both. Enjoyed it. Bye.
Thank you. Bye-bye.